So good morning, good afternoon, and good evening, everyone, depending where you're joining us from. Welcome to the ISV July mini symposium, and thank you for taking the time to be with us today as we explore exciting advances in immunotherapy, vaccines, and immune-mediated diseases. Speakers representing academia, biotech, and the pharma industry, and we look forward to having a series of engaging presentations and discussions today. Following each presentation, we will have a dedicated session for Q&A. So please feel free to submit your questions through the talk feature, or the Q&A feature, and we'll address the questions immediately after each. Our first speaker, Dr. Jeffrey Ulmer. Dr. Jeffrey Ulmer has spent more than 3 decades at the forefront of vaccine research and development and has held senior positions at Merck, Chiron, Novartis, and GSK. His scientific contributions have helped advance multiple vaccine technology platforms and resulted in more and 11 patents. He currently serves as the president of TechImmune and is a fellow and the current treasurer of ISV. Today, Dr. Ulmer will present on T-cell targeted immunotherapy for the prevention and treatment of long COVID. This presentation will explore an innovative immunotherapeutic approach to addressing one of the most significant ongoing challenges following the COVID-19 pandemic. So with that, I will pass it over to Jeff.
Well, thank you very much, Corey, for the kind introduction. It's my distinct pleasure to be able to participate today. I'm sure you all remember quite clearly the early days of the COVID-19 pandemic when up to 100,000 people were dying every week of the disease. But fortunately, for most of us, having multiple exposures to the virus and multiple vaccinations, we have enough underlying immunity that it protects most of us from the serious outcomes of the disease. So problem solved, right? But sadly, no. COVID-19 actually still kills more people than does influenza. The virus has gone into an endemic state, and there's no solution on the horizon. Another very serious, underappreciated consequence of COVID-19 infection is a chronic condition called long COVID that has patients that exceed over 400 million people globally have this disease. And it's estimated that about 10% or more of all new infections progress to long COVID. And in the US, there's estimated to be about 5 to 7% of the total population suffer from some form of long COVID. It can be so debilitating that people can't function and have normal lives. And it's estimated that up to several million people are still out of work due to long COVID. And as you can imagine, the economic burden is staggering, greater than $1 trillion annually. Unfortunately, there's no approved treatments or even diagnostics that helps us better to understand or definitively diagnose someone with long COVID. The disease spares no one. It cuts across age groups, genders, and all demographic groups. Fortunately, though, we are gaining a better understanding of the nature of this disease and potential root causes. And here is the current hypothesis that's favored by most KOLs. Most people who get an acute SARS-CoV-2 infection have symptoms for 5 to 7 days or so, and then they resolve those symptoms through a functioning immune response. But as I said, about 10% of those people go on and simply cannot clear the virus and establish virus reservoirs in a variety of tissues throughout the body. It's associated with an exhausted phenotype of the antiviral T-cell responses for both CD4s and CD8s, resulting in a chronic inflammation in the downstream sequelae. So our strategy is to target these exhausted T cells with an immunotherapy, specifically targeting proteins from the virus to revert them to a functional phenotype, clear the virus reservoirs, decrease the inflammation, and then ameliorate disease. So we've taken 5 steps to this end. Starting back in the mid of 2020, we we're embarking on developing a next generation vaccine that could induce broad-based immunity, not just antibodies against spike, but also T-cell responses against conserved proteins of the virus. So our first step was to sequence all of the genomes of coronavirus that were currently available then. And we identified these 10 viral proteins as being the most conserved amongst all of the virus strains. So this provided a starting point for developing a vaccine that could confer cross-protective immunity. The second step was to go directly into COVID-19 patients and ask the question whether these antigens are recognized by the human immune system and if there's any relationship between the T-cell responses against these proteins and disease outcome. So about the middle of 2020, we collected PBMCs from unvaccinated COVID-19 patients very early during their disease course, around day 4 or day 5, and then followed them for disease outcome and measured the quantity and quality of antigen-specific T-cell responses. And what you see is a very clear relationship. For those people who had high levels of antiviral T-cell responses early during their infection, went on to have very good outcomes, either no symptoms or mild symptoms. In contrast, those people who had very low or no detectable levels of antiviral T cells at the beginning of their disease went on to have bad outcomes. So this was very good evidence that T cells play an important role in protection from COVID-19 disease. And given that these people were unvaccinated, it's likely a recall response from cross-protective cross-reactive T cell responses from a prior coronavirus infection. I think validates, at least in these human samples, that these proteins are bona fide targets for protective T cell responses. So the third step was then to test whether these proteins, in the form of using the RNA LNP platform to screen in animal models whether they could confer protective immunity. So we used the hamster model for this, and we immunized twice on day 0 and day 21 with a low dose of mRNA, encoding each of these individual viral proteins. And then we challenged with the virulent Delta strain of SARS-CoV-2. And what consistently came out were 3 proteins, NSP2, NSP14, and nuclear protein, as conferring protective immunity on the basis of morbidity as shown here, but also reduction in virus titers and lung pathology. So these 3 proteins formed the basis of our vaccine. The value of targeting these is clearly illustrated here, where when you compare the number of amino acid changes that has occurred in these proteins versus spike, for example, you see that spike protein has 58 and 63 amino acid changes since the original ancestral Wuhan strain in the current vaccines. But the 3 proteins that we're targeting here, by virtue of their conservation, have no amino acid changes. So these proteins have the best chance to confer cross-strain protective immunity. So the fourth step was to go into long COVID patients and see whether T-cell responses in long COVID patients, there was a phenotype of T-cell responses that could distinguish long COVID patients versus not long COVID patients. So we investigated 2 cohorts of individuals, those that had active long COVID, but also those who'd had an acute infection of COVID-19, recovered from it, and never progressed to long COVID. So we're directly comparing long COVID patients versus non-long COVID patients. And we collected PBMCs from these individuals and measured the quantity and quality of the viral specific T-cell responses. And the data is shown here, CD4 responses on the top and CD8 responses on the bottom. And here we're looking at function. On the left, granzyme B, interferon gamma as markers of function, and then on the right, tissue resident markers, CD69, CD103, et cetera. And I think you can clearly see that those individuals that recovered from acute COVID in the lighter bars have much higher levels of functional T-cell responses than the active long COVID patients, indicating a deficit in these patients. And then conversely, when you look at exhaustion markers, you see that the active long COVID patients in the darker bars here have much higher levels of exhaustion on their T-cell responses. So these data are consistent with the hypothesis that long COVID patients have a deficit. They have dysfunctional antiviral T cell responses, but it also suggests that this could form the basis of a biomarker or diagnostic assay that we could use to definitively say these people have long COVID caused by SARS-CoV-2 versus those people who have symptoms that are similar to long COVID, but maybe caused by something else. And we would also plan to use this as a selection criteria for patients entering into a clinical trial so that we could assure that the people we intend to treat in a clinical trial actually have long COVID, but then we can also follow them and use it as an outcome measure to see whether or not we can revert the phenotype of T cells from an exhausted phenotype to a functional phenotype. And then the last step was to directly test in a mouse model of long COVID whether an intervention with mRNA encoding these three T cell antigens, NSP2, NSP14, and nucleoprotein, could have a beneficial effect in a long COVID mouse model. So to that end, we established a long COVID model using a triple transgenic mouse model, expressing the ACE2 receptor to enable infection with human SARS-CoV-2, but also alleles for MHC class 1 and class 2 so that we can look at human T cell responses. So this first study that I'll show, the specific goal was to evaluate whether intervention during the acute phase of infection could prevent progression to an establishment of long COVID. So we infected the mice with the Delta strain at day 0, and then we intervened with immunotherapy, as I said, based on mRNA, LNP encoding these three antigens at day 10 and day 31. And then we tested the animals with a battery of cognitive and behavioral tests for symptoms of long COVID. And then we collected tissues from the animals later on to look for the magnitude of and quality of the T cell responses and whether there were tissue virus reservoirs. So with regard to the T cell responses, on the left are markers of function, again, granzyme B, interferon gamma, CD69, CD4 responses on the top, CD8 on the bottom. And you can see, just like in the humans, those animals that were infected but untreated had relatively low levels of antiviral functional T cell responses, but high levels of exhaustion markers, PD1, TIM3, for example. Whereas those animals that received the treatment during the acute phase of infection had much higher levels of functional T cell responses and much lower levels of the exhaustion markers. So recapitulating the human situation quite nicely. And again, consistent with the hypothesis that long COVID is associated with a deficit of functional T cell responses, but importantly, that intervening with an immunotherapy like this, you can revert the phenotype of their T cell responses. So what's the effect on virus? So the animals that were infected and untreated, as you can see with the open circles, in all the tissues we tested, had very high levels of viral RNA up to at least 125 days after the initial infection. Whereas those animals that were treated with immunotherapy had 2 to 3 to 4 log reduction in some cases down to baseline by about day 100 or so. So those functional T cell responses that I showed you earlier are associated, as you might expect, with clearance of the virus reservoirs. But what happens with the symptomology? So we partnered with the neurobiology group at UC Irvine, who had already set up a number of standardized tests for testing a variety of neurological, cognitive, and behavioral deficits in mice. And so common symptoms of long COVID in humans are depression, antisocial behavior, social recognition and memory deficits, short-term memory and exploration deficits, and chronic fatigue. And there are assays and tests that are used in the neurological field for all of these things, and they're shown over here on the right. I don't have time to show you all, but I'll just show you a couple of examples. But in every case here, these tests, we've shown that the intervention with immunotherapy has a beneficial effect on the symptomology. So with regard to depression, the test is actually called the tail suspension test, where the mouse is suspended by the tail from the top of the chamber. And that what you measure is the amount of time the mouse spends trying to escape from this predicament. Under normal circumstances, the mice will have sustained effort. And that's what you see with the green arrows. You see that the mice will struggle to right themselves for more than 5 or 6 minutes. Whereas abnormal behavior, depressive behavior, they have short-lived effort and they give up very quickly. And you can see animals that were infected but untreated gave up within about a minute or so. And so what we're looking at here is the effect of immunotherapy at different doses, 1.1 and 0.01 micrograms. And you can see that there's a dose-dependent protective effect. That is, the intervention with the immunotherapy gives much more normal behavior in terms of depressive-like behavior than the untreated animals. I don't have the data to show you here, but when we took this group of animals, got the lowest dose of RNA, we boosted them with the 1 microgram dose, and we could revert the phenotype to a protective phenotype. That is, the animals that that behaved in a depressive manner after the boost with the 1 microgram were back to normal. So you can prevent progression to long COVID as measured by this assay, as well as all the other 4 assays. So the second study was to test whether intervention in established disease could have a beneficial outcome. So the mice were infected on day 0, but not treated until day 28. And this is a point in time in which they have persistent virus reservoirs, they have dysfunctional T cells, and they display the variety of cognitive and behavioral deficits that I described earlier. So similarly, we tested the cognitive and behavioral tests first, and then we looked for T cell responses and virus titers. And with regard to T cells and virus titers, like I showed you earlier in intervening during the acute phase, by treating established long COVID, you can revert or reverse the T cell function. So T cell exhaustion here on the left, the untreated animals maintain high levels of exhaustion markers, that's the open bars, but the treated animals have much lower levels of exhaustion markers, indicating that we've reverted them from an exhausted phenotype to a functional phenotype. And then conversely, you see that the untreated animals had low levels of functional responses, but the treated animals had much higher levels. And in terms of virus titer, you can see that we have 3+ log reduction in virus titers in the treated animals, but the untreated animals showed no difference in their virus titers. This is pre-treatment, and then this is 21 days after treatment, but in the untreated group. So this is day 28 versus day 49. Very little reduction in virus, but a substantial reduction when you intervene with treatment. An important control here is we tested to make sure that this was virus specific. And when you treat with mRNA encoding HSV-GD, you see no positive effect, indicating that the effect here is definitely on the antigen-specific immune responses. And then with regard to the behavioral tests, this is a different test. It's called it tests the antisocial and withdrawal behaviors. So you put a mouse in a central chamber, you expose it to an empty cage on the right for 10 minutes, and then you open the left chamber and it has a cage with another mouse in it. So normal behavior, as you might expect, mice are curious, they'll go over and they'll be exploring the new mouse. Abnormal behavior, the mice doesn't really care that there's a new mouse there and spend most of its time in the central chamber. And that's exactly what you see. So this is the mouse that was the healthy uninfected control. So this is normal levels of exploratory behavior. This is the amount of behavior, exploratory behavior in the infected and untreated animals. You can see much, much less interest in exploring the new mouse. They spend most of their time in the central chamber. However, treatment with the immunotherapy restores completely normal behavior. They spend as much time as an uninfected mouse exploring the new mouse, and very little spent by itself. And then again, the non-specific, the irrelevant antigen control shows levels just like the untreated animals. So I think we can say we have established a mouse model that recapitulates human disease, persistent virus reservoirs in multiple organs, T cells with an exhausted phenotype, and a variety of behavioral, cognitive, and physical deficits after the acute infection, and that lasts for many months, up to at least 125 days. But intervening with the treatment, either during the acute phase of infection or after establishment of long COVID, reverts to a strong antiviral functional T cell response, reduces the exhaustive phenotype, eliminates or reduces virus reservoirs, and establishes normal cognitive and physical endurance behaviors. So all of this put together suggests that we have a good preclinical proof of concept that one, the long COVID is associated with this T cell deficit, then could be targeted with an immunotherapy to reverse their symptoms. So we envision two patient populations. Obviously, those millions of people who are suffering from established long COVID would be a primary target, where we would aim to reverse the T cell function, induce functional CD4 and CD8 T cell responses that could help clear the virus reservoirs and enhance T cell responses, thereby directly addressing the root cause of disease and eliminate their long COVID symptoms. We also could envision treating during the acute phase in a manner similar to what happens now. Many people who come down with COVID-19 will seek their Paxlovid treatment, for example. And so if we intervene during the acute phase, we would aim to induce functional CD8 and CD4 T cell responses that could minimize the acute disease, but also reduce the side effects and the virus rebound that's often seen with Paxlovid. But from the long COVID perspective, we would aim to prevent the progression to long COVID, which is defined as having persistent symptoms for 3 or more months after the acute infection. And so with that, I'll stop there, and thank you for your attention. I'd be happy to answer any questions.
Great. Sounds good. Thank you, Jeff. So the first question for you is from Nick Wilcox, and he asks, are the severe COVID-19 patients with anti-type 1 interferon autoantibodies at greater or lower risk of long COVID?
I'm not sure that anyone has directly, so the autoantibodies would be against interferon specifically. What are the antibodies targeting, I guess, is my question. Now, there are in the later stages of severe long COVID, some people do generate autoantibodies against a variety of different self proteins. So the progression from to long COVID is inflammation, the persistent virus reservoirs. Some people get reactivation of latent viruses like EBV, and then autoimmune responses as well. But I'm not familiar with work that specifically looks at autoantibodies against interferon. Obviously, in that case, once people progress to have symptomology because of autoimmune responses or reactivation of other viruses, an intervention that specifically targets the SARS-CoV-2 proteins might not be as effective as targeting that earlier during the disease, but that remains to be seen.
Just a clarification, he also added, these are pre-existing high titer neutralizing anti-interferon autoantibodies.
Oh, in that case, yeah, I'm not familiar. There may be some work about that, but I haven't seen anything in the literature about that, so I'm afraid I don't have the answer.
Jeff, question for you are you intrinsically reversing T cell dysfunction of nascent antigen-specific T cells, or are you actually priming for new highly functional T cells? With the former, what are the mechanisms by doing that? Because you don't have the checkpoint inhibitors here, or anything for that. Very strong reversal agents.
It's a good question, and we don't have the answer to that. I mean, as you say, the two potential ways we're going from a dysfunctional phenotype to a functional one is that you actually revert the actual existing T cells to have a better phenotype, or you're enriching and enhancing functional cells that take over, and because of the half-life of the other cells, they disappear. What I can say is that we see a complete reversal, at least in the animal model, within 3 weeks after a single administration of the immunotherapy. So I wouldn't expect that all of those exhausted T cells would have disappeared within 21 days. So, and it could be a proportionality that you're actually, you have a low decay of the exhausted phenotypes, but you're enhancing such a high level of functional cells that, as a proportion of total T cells, you have much higher levels of functionality. That is something we're interested to get to, but we don't have an answer.
And could you comment a bit in terms of what your development plans for these vaccines, if you can?
Well, as I showed at the end there, we envision 2 patient populations treating existing long COVID patients for reversal of their symptoms, as well as during the acute phase to prevent progression to long COVID. And so we plan to test that in a phase 1/2 clinical trial.
There are more questions. Corey?
Sounds good. So the next
There are
question,
more. Yeah,
Jeff,
go ahead.
there is so how do you account for immunosuppressive treatment? So we just talked about a potential acquired immunodeficiency, right? So for those, since you're talking about the T cell here, if patients are going under immunosuppressive treatment, is there any issue with your program?
Yeah, it's certainly a potential issue. And the question would be, right, if we plan to go into a population of patients like that, we would have to evaluate that carefully. And there would be a way to do that in the animal models to see whether or not there was either counterproductive or ineffective, in that circumstance. But it's an open question. And obviously, we would probably not include those individuals in the first steps of the clinical program. But as with success, you'd be expanding to additional populations of patients that are undergoing other treatments.
Next question is long COVID physiologically distinct from ME, chronic fatigue syndrome, and Guillain-Barré?
That's a good question because there are many people out there that have symptoms that look similar to long COVID, but may not actually have long COVID. And that's where we think that the biomarker to definitively say this person or does not have long COVID is going to be very useful. But yes, chronic fatigue syndrome, Lyme disease, there are a number of other syndromes like this that have similar symptomologies of chronic fatigue. So we would definitely need to definitively identify bona fide long COVID patients to make sure we're not treating those people that have no chance of responding to the immunotherapy.
Next question is, what is the role of the T cell directed sequences? Has a control without these sequences been tested?
I assume they mean the specific antigen sequences that the epitopes, the CD4 and CD8 epitopes that are within the. So just to clarify, the treatment includes the entire genes of NSP2, NSP14, and nuclear protein, which contain many different epitopes. So we have mapped regions of the protein for which are inducing the T cell responses, but we're not specifically targeting specific discrete epitopes in a string of beads fashion. But the control for the epitopes was the irrelevant antigen encoding GD, which, as I showed, had no beneficial effect on either reducing virus titers or reversing symptomology. So from that control, we conclude that the effects are specific to SARS-CoV-2 specific T cell epitopes within those 3 proteins.
Thanks, Jeff. And last question before we move on to the next speaker. What are the options to use this strategy for preventative vaccination or adding the strategy to endemic SARS-CoV-2 vaccination?
I think both. I mean, as I said, we started out with the intent to make a broad spectrum preventive vaccine that had not only spike in it for antibodies, but also these T cell antigens. And we have very convincing data that if you include T cell antigens together with spike, you have a much better vaccine. There's almost a synergistic effect. So yes, I think you could use it as a prevention as well as a treatment. And there are data that even despite alone-based vaccines can reduce the likelihood that you progress from acute infection to long COVID. So I think including those T cell antigens would only make that more effective. Danny, you're muted.
Sorry. Let's thank Jeff for the presentation and very interesting discussion and presentation on the vaccine against long COVID. We'll now move to the second speaker. It's my pleasure to introduce Kirsten Schneider-Ohrum. She's the Associate VP as well as the Global Project Head for Sanofi's Therapeutic Acne vaccine. Kirsten joined Sanofi in 2022, but prior to that, she has held significant leadership positions when it comes to vaccine programs at GSK as well as at AstraZeneca. So let's give the floor to Kirsten.
Sorry about that. Somehow my unmute button didn't work. Thank you so much, Danny, for the kind introduction. And I'm really excited to be able to present to you today our therapeutic acne vaccine program. First, we have to get the disclosures out of the way. As also mentioned by Danny, I'm a Sanofi employee, and with that, I might hold shares or stock options in the company. The way I would like to present the program to you is in three buckets. One, first, the burden of disease. So explain to you what is acne, what does it represent to the patients, tell you more about acne pathophysiology, and then how we are trying to provide a treatment option to these patients via a therapeutic vaccination approach. First, on the burden of disease, I would like to really highlight that this is not a cosmetic issue. It's a chronic inflammatory disease with significant public health impact. It's one of the most prevalent skin conditions globally, and there are about 8 million cases in the US, about 23 million in Europe, and as you can see here, there's more than 230 million prevalent cases globally. The disease can present in different severities. It goes from mild, moderate to severe disease. And it's not only a transient teenage problem. Acne is of chronic nature, and the disease can persist well into adulthood, requiring long-term management. And sometimes the disease even starts representing in adulthood. There's quite a psychosocial impact on these patients, and I will talk more about that on the next slide. But the patients can experience anxiety, depression, reduced quality of life, and particularly in their adolescent years. There are current treatments. There's quite an array of treatments, but for example, antibiotics, they contribute to a growing antimicrobial resistance crisis, making this not just a dermatological issue, but also a public health concern. The economic impact is significant, so direct treatment costs, productivity loss, and despite available therapies, there remains several unmet needs for patients who do not respond adequately or do that relapse within their disease course. As mentioned earlier, I would like to spend a little bit more time on the mental health impact acne can have. It's quite striking because 95% of acne patients can develop permanent post-acne scarring, and that, of course, impacts significantly their body image, self-esteem. We see anxiety rates of 38 to 66%, and depression in 22 to 65% of the adolescents with moderate to severe acne. And what is really sobering is that you even see a suicidal ideation in roughly 10% of these patients. So it's a disease that shapes adolescent identity, and is actually quite touching when we have conversations in the context of patient research, how much their life is influenced by acne in their adolescent years. So these impacts really warrant therapeutic intervention. And here I show you, before I jump into what is available nowadays and what are the shortcomings, a little bit more granularity on the disease burden and how it represents over the course of the age. As you can see, there's really a peak in the adolescent years and in the young adolescent age groups, and there's a little bit of a higher incidence in women and prevalence in women than in men. And excuse me one sec, I have a little bit experiencing a cold. So I have to take a sip of water in between. Here now on the current treatment landscape. So why has this not been solved, right? And there's a lot of activity in the dermatology space on developing novel treatments, but unfortunately, we haven't really hit all the desired treatment attributes in one drug or approach just yet. As I mentioned before, systemic antibiotics and as topical treatments have several shortcomings, such as antimicrobial resistance. There's usually a relapse once the drug is stopped. And with that, it's a really a frequent, long, and challenging cycle of trying something, stopping, going to a new drug. Many people are familiar, even if you're not an acne sufferer, with isotretinoin, brand name Accutane. It's a very effective drug. It can have curative effect in patients, but it comes with some shortcomings. There is definitely identified safety risks, and due to that, the prescription is regulated and the indication is limited to severe cases. It shows teratogenicity, and with that, women need to be under a strict birth control regimen when they take this drug. And in both genders, there has to be monitoring of also their certain liver values as well. These gaps really create space for a therapeutic vaccine approach that I will talk to you in a little bit after I had the chance to explain a little bit more on acne pathophysiology. It's really more than just a clogged pore, and it's really not an hygiene problem, which often is assumed. It's really a result of a complex multi-layered interaction between the host and key skin bacteria, Cutibacterium acnes. The pathophysiology involves 4 interconnected mechanisms. So for one, we have excess sebum production and also there's different sebum compositions that are very much driven by hormonal changes in the context of puberty. There's also abnormal follicular keratinization, and C. acnes colonization leads to inflammatory processes. All of these factors, of course, influence each other, and it's really difficult to interrupt the cycle, especially by targeting only certain parameters rather than at least 2 pillars of what's driving acne. The host immune response drives much of this inflammation associated with the visible acne lesions. We go a little bit deeper now in the next slide to look more specifically into how C. acnes is influencing the pathophysiology. C. acne is a commensal organism, so it's part of the normal skin microbiome in virtually everyone. But in acne-prone skin, specific strains undergo what we can think of as a switch from benign colonizer to active driver of inflammation. And this is in part driven by environmental modified condition as that I talked about earlier, such as sebum composition changes due to hormonal changes. It mechanistically, it involves innate immune activation, think toll-like receptor engagement, inflammasome activity, followed by adaptive responses that are skewed towards the Th17, Th1 phenotype. This creates a self-sustaining inflammatory loop. And really critical to point out, it's not the acnes as a species that's the problem. It's specific virulence-associated strains and the antigens they express. So it's really a distinction is important in how we design our vaccine. Here you see a image from a longitudinal study that was tracking the facial skin microbiome through puberty. So what you see here, T1, T2 is early adolescence, and then T3 to T5 is late adolescence in normal skin or in acneic skin. And I want to point your attention to the blue Cutibacterium acnes relative abundance in these patients. And what you can see, it's really a dysbiosis. It's an imbalance, and it's not really a new infection that is causing this. And that really reframes our therapeutic approach. We are not trying to eradicate the acne. That would actually be very counterproductive and undesirable given its normal role in skin homeostasis. Instead, we are trying to selectively target the pathogenic strains and virulence factors driving this dysbiosis and support the skin's return to a healthy microbial balance. So we are not vaccinating against the pathogen to prevent an infection, but rather we are modulating an existing chronic host microbiome interaction and would like to restore the equilibrium. So now that I introduced you to the burden of disease and also the acne pathophysiology, I would like to speak a little bit more about our approach. We chose an mRNA platform-based approach, and I do not think I have to give you any introduction on mRNA technology. I think we are all quite familiar with it now since the COVID era. What I do want to highlight, though, is why we consider this platform suited as to target acne. As you know, you can design it. It's speedy in the production. It's a fast platform. It provides strong immunogenicity without needing a separate adjuvant, and critically, the flexibility to combine multiple antigens in a single formulation. And this flexibility mattered because our antigen selection strategy is multivalent. So we are targeting 3 membrane proteins involved in adhesion and colonization of C. acnes and a secreted virulence factor that is implicated in inflammation. These antigens were identified by screening approximately 200 C. acnes proteins and identify antigens that were differentially expressed in the context of C. acnes strains driving acne pathophysiology. This work was performed in large part by Origin. It's an Austrian biotech which Sanofi acquired in 2021 and is really a very nice example of the work that our external R&D and BD colleagues did. So the logic here really mirrors a multivalent vaccine strategy, and we would like to hit multiple mechanisms simultaneously. For one, we would like to neutralize secreted virulence factors, and then also target surface protein that are critical for adhesion. And we are also anticipating to induce OPK antibodies as well. So of course, before you go into the clinic, you have to conduct some preclinical studies. I would like to highlight that unfortunately, there's no good animal model available that recapitulates acne as we see it in humans. There is mouse infection models available, but they are not really recapitulating the disease that we see in these patients. So we limited, therefore, our preclinical investigation to immunogenicity studies and toxicology studies that are, of course, required. So how does this actually work now from an immune response that we see? So first, we wanted to confirm that the mRNA-expressed antigens induce functional immune responses. And for antigen 1 and antigen 2, and you might wonder, didn't you say you have 3 surface antigen? We do, because antigen 1 here is a chimera of 2 antigens. Antigen 2 is the third surface antigen, and then here labeled at antigen 3 is our virulence factor. So for antigen 1 and antigen 2, we looked at opsophagocytic killing, and we compared recombinant protein expressed vaccine versus mRNA expressed via mRNA expressed antigens, and we indeed induced OPK titers using both platforms. We also see neutralization of the inflammatory factor after immunization with mRNA that encodes for the virulence factor. So what is important, of course, is to ensure that we do not see interference once we combine all antigens together. And here in the OPK assay, you can see either mRNA antigen 1, 2 by itself, combination of all 3, and we do not see a reduction in an OPK titer. And the same was also true if it comes to the neutralization of the virulence factor. So this preclinical data and of course a lot of other data pieces allowed us to move into the clinic in 2024. And I will tell you a little bit more about our ongoing clinical stage program. We are running 2 parallel phase 1/2 studies in adults. So one in moderate to severe patients, and the other one we are in mild patients that we are exploring as well. From there, we plan to move into an adolescent phase 2 still in 2026. We are actually anticipating start of the study very soon. And this is, of course, important as adolescents are our ultimate target population. But starting in adults is, of course, appropriate and the conventional safety first approach. Beyond the interventional trials, we also have a translational study ongoing in collaboration with the Agency for Science and Technology and Research in Singapore and the National Skin Center in Singapore. And with this study, we would like to characterize immune and microbiome profiles across the full severity spectrum. So we are enrolling mild, moderate, and severe patients and healthy volunteers as comparator. And this work will hopefully help us to refine biomarkers and better understand who responds or who does not respond and why. Here, a little bit more details of our lead trial, which is our phase 1/2 study in adults with moderate to severe acne. This is a first in human randomized placebo-controlled multi-arm and dose-finding study enrolling approximately 800 adults, both men and women, ages 18 to 45. We are running this trial currently in the US, Australia, and Canada. The study started in May 2024, and with long-term extensions, it's assumed to last until November 2028. So the study objective is, of course, safety, immunogenicity, but we are also looking at efficacy in this trial as well, which will be important guiding study to determine the go, no go to phase 3. So I hope I was able to show you that acne is a chronic inflammatory disease with a major unmet need and significant burden. That C. acnes is really an important driver in the dysbiosis and inflammation to provide the rationale to target C. acnes with a therapeutic vaccine. Um, it is really a paradigm shift, a therapeutic vaccine for microbiome modulation. And we hope if this approach in the context of acne is successful, that this could open up additional possibilities in other inflammatory diseases or other diseases where the microbiome plays a role. And with that, I would like to thank you very much for your attention and open up for questions.
Thank you so much, Kirsten. We're open up for questions. Do we have anything in the Q&A board? There's a question here about why would you not choose a prophylactic approach in this case, as opposed to a therapeutic, right?
Yeah, it's a really good question, and we actually get that question a lot from our dermatologists that we engage a lot as key experts. And of course, that would be the holy grail, right? If you could prevent acne in the first place. We opted to first address this in a therapeutic way. For one, we feel that the risk-benefit justification, particularly for an mRNA vaccine, is more appropriate in the therapeutic setting. Not to say if we see that this has success, that we could explore prophylactic application eventually. But our initial target is really to develop something for existing patients, see whether we can have an effect, and then consider expanding into a prophylactic setting down the road. But we feel we first have to really demonstrate, particularly that we are not having negative impact on the microbiome by targeting C. acnes. So we are really closely monitoring also whether there's other diseases, skin diseases that we might see more frequently in patients that received the vaccine. And we are also following up the microbiome via transcriptomics and several ways, and tape stripping and swabs, biopsies, to really for one, see what's going on. Do we have an impact on these specific strains? Are we specific enough? And to see, do we see the correct modulation that we expect?
And Kirsten, obviously, C. acnes is certainly quite a novel target for vaccine industry. And as you pointed out, it's not a cosmetology issue. There are psychological issues, big psychological issues with that disease itself that therapeutic vaccine can offer solutions to. Are there other approaches currently in the field for novel approaches aside from host-directed drug development that are being pursued right now, aside from the therapeutic vaccine?
Yes, there's actually another approach that is quite interesting. There is a French company that is developing a bacteriophage type of approach. They developed a bacteriophage that specifically targets C. acne strains associated with acne pathophysiology and deliver a CRISPR payload and are able to eliminate selectively these strains. They are in early clinical stages, more like translational stage at this time, to identify a good way to topically administer the bacteriophage. But then the next goal for them is also to explore it in the clinic. So that's another quite interesting approach as well, specifically also targeting C. acnes. There's also a novel molecule that was presented at recent congresses, which is targeting specific the lipid metabolism of the host. And that's also a novel approach, and very selectively is only going after specific enzyme responsible or part of the lipid metabolism. And that was recently presented. So they had positive phase 3 results.
Are you exploring repeat dosing in these trials? Is the goal more like Accutane-like efficacy?
So yes, we are exploring repeat dosing. So for one, we had a primary series is we are exploring different dosing regimens. And we are also considering maintenance dosing, for which we, of course, have to see how long is the additional effect lasting and at which point would a maintenance dose be appropriate. So that's definitely something that is evaluated. The other question was isotretinoin-like efficacy. Isotretinoin has honestly very, very good efficacy, and we do not anticipate to see the same levels as what you see with isotretinoin. What we want to see a similar long-lasting effect, because that's what we see as a key differentiator and gap in the treatment landscape, so that even once you receive the first course, that you for many months do not need another dose. So it's a much easier for the patient rather than having to do daily treatments. And the other element is that we want to be superior if it comes to the safety profile compared to isotretinoin. But at this point, we do not believe that we can hit the same level of efficacy as what is seen with isotretinoin.
Yeah. And now that you mentioned about safety, what do you think about the potential side effects or safety of an acne vaccine given its mRNA-based for the adolescent population?
No. So that's a good question, and of course we assume to see similar side effects that were observed with COVID vaccination, but of course at a lesser degree because the technology since then has evolved. Our proprietary LNP delivery system, one of the big elements is also, of course, to reduce the reactogenicity profile to have a better tolerability than what was seen with the COVID vaccination. But we expect still to see these type of transient effects in the adolescents. And of course, we have to have it as a level that is it's safe and also tolerable for these patients, and that's definitely part of the clinical development. That is, integral part of the clinical development to look at these type of effects.
Probably if I could see if I can get two more questions, but can you describe the immune responses with natural immune responses against this microbe, and do they cure the acne, or do they, or what's the correlation, say, for example, resolution of the acne?
No, it's not really that the immune responses per se, the way they are driven to these pathogenic strains, would contribute to ultimately resolving the acne. That said, of course, as you probably also know, is acne is not always constantly the same. Particularly hormonally driven, there will be changes in the sebum composition, which then might be less favorable or more favorable for the pathogen to drive. What is also seen is that you have a higher level or a reduced activity of regulatory T cells. So it almost seems as if you lose the tolerance that you usually have to this commensal, and have an active immune response and treat it like a non-commensal. And that is what is part of the problem. So in a way, you want to modulate the immune response to enable it to so to say quiet down, Or as we are also, the other hypothesis is by eliminating particularly or curbing these pathogenic strains, we can have a positive effect by reducing overall the immune response or like the undesirable immune response to these strains.
We have a lot more questions here, and unfortunately, we have to move on. I suppose we can provide contacts to Kirsten, and folks can reach out to Kirsten with your
Sure.
additional questions.
Yeah, and I'm also happy then to consult with my colleagues. They can probably even give much more adequate responses than myself. So I would like to thank you again for your attention and Danny for moderating the Q&A.
Thank you very much, Kirsten. Let's now move on to the third speaker. The third speaker is Dr. Clemens. He is Executive Director at Merck Research Laboratories. Krepler is he leads the Intismeran Autogene asset development team, which is a very important asset for the company, especially in the area of cancer immunotherapy. Since joining Merck in 2017, he played a pivotal role in advancing the melanoma therapies, notably contributing to the first approval of pembrolizumab or Keytruda in an adjuvant setting. With this, let's welcome Dr. Krepler.
Thank you, Danny. Thank you for the invitation to speak and to present our work here. And yeah, thank you to previous speakers as well. Really interesting. I learned a lot already. I want to talk to you today about Intismeran Autogene. This is an mRNA-based individualized neoantigen therapy to help a patient's immune system target their cancer. So we're switching here to oncology. I will give you an overview of the mechanism of action first, because it is operationally quite complex, and then go into our clinical program afterwards. First to mention, this is a collaboration between Merck and Moderna. It is a really unique and strong partnership. Merck, of course, is a big pharma company with a very deep expertise in oncology, versus Moderna, a nowadays medium-sized biotech, but a visionary leader in delivering novel mRNA medicines, as you remember from the COVID pandemic. Brief overview of the history. As you know, and the previous speaker also mentioned, mRNA technology is not new and has steadily advanced since the 1960s, concurrently with lipid nanoparticle advancements. Combined with advancements and affordability of NGS sequencing, this has now combined to an opportunity to move individualized neoantigen therapies into the clinic. And this was initiated in 2017, so way before mRNA vaccines had shown clinical benefit, and built on a long history of cancer vaccine trials that unfortunately all or most of them failed. However, in June 2017, in a phase 1 study, interesting data did come out. This was led by Moderna, specifically in melanoma skin cancer. This led to a phase 2 study in February 2019, initiated to study pembrolizumab combined with mRNA therapeutic vaccine, back then called mRNA-4157. Pembrolizumab, of course, is standard of care therapy in melanoma. Then in 2020, 2021, COVID pandemic hit, and Moderna had to shift all the efforts to developing a cancer vaccine against COVID from cancer vaccine development. The initial focus was on cancer vaccines, and during the pandemic, although the phase 2 study continued to enroll and patients continued to be followed up, Moderna really shifted from being a very small company to solving the COVID pandemic together with other companies. And when we came out of this in November 2022, the phase 2 study read out and showed very interesting results. From there, we then, as Merck, started to develop a phase 3 program based on these phase 2 data. And since then, studies are operationalized by Merck, still in collaboration with Moderna, who is manufacturing this therapeutic vaccine or INT. So how does this work, this manufacturing? This is done at the Moderna facility. On the left, you can see the first point is patients need to provide a tissue and a blood sample. This is needed for next generation sequencing, which happens in step number 2, to identify neoantigen mutations in the patient's individual tumor. Based on this, the neoantigen therapy is designed, step number 3, as an mRNA concatemer encoding up to 34 neoantigens. One lot per patient is then manufactured and sent back to the site and administered to the patient. So one batch per patient, truly individualized. On the right, to show you a little bit more detail at how this works, this is a deterministic machine learning algorithm that selects the neoantigens. It is based on the tumor DNA sequence, the patient's normal DNA sequence, tumor RNA sequence, and HLA phenotyping. All of this comes together to annotate mutations, peptides, and HLA type to then select the 34 selected neoantigens. This is then concatenated into an mRNA design, packaged in lipid nanoparticles and delivered to the patients. So important to remember here is that the tumor tissue is the critical starting point for successful design. The mechanism of action, walking you through here from the top left, number 1, the INT, which is the mRNA that encodes the tumor-specific neoantigens, is injected IM, is taken up by antigen-presenting cells, blown up on the right under number 3. The LNP is taken up by the endosome. The mRNA then is set free and translated into a polypeptide. These peptides are broken up in the proteasome and presented on MHC class 1 and MHC class 2 to CD8 and CD4 T cells. So these CD8 and CD4 T cells will then be specific for one of the 34 neoantigens. They will expand and start patrolling the periphery and find tumor cells that express or present these neoantigens, engage and destroy those tumor cells, ideally on the left here, which will then hopefully also lead to a phenomenon called epitope spreading, where new neoantigens are set free by the dying tumor cells to lead to an even further activation of the immune system against these tumor cells, leading to an immune control of the individual cancer cells. I showed you before the process, but not how long this takes. So at the moment in our clinical trial program, you can see how many steps are involved. This takes roughly 6 weeks. So from the time that the screening tissue arrives at the manufacturer for NGS sequencing, this takes 6 weeks. This does not take into account the time that it takes for the site to obtain the tissue. Sometimes patients are seen in other sites, especially in melanoma. They are often seen with dermatologists, and the tissue is then stored in external pathology labs. So this is a variable time here that it takes for the treating physician to obtain the tissue, obtain the blood sample, send it to Moderna, and then the NGS sequencing can commence and the manufacturing. And this process takes roughly 6 weeks. We're hoping that this can be reduced further in the future with further improvements in the technology. But this is something to keep in mind, and is one of the reasons why we're focusing on early stage cancer. Due to the turnaround time, late stage cancer patients often cannot wait for for this extended period. How will this work in practice in the clinic? This is not an approved therapy at the moment, but this is a look ahead how we envision this will be working in the clinic once approved. The patient is seen by the oncologist and identified as a candidate for INT. The HCP, the healthcare provider, then registers the patient in a portal, orders the INT. Number 3, the blood and tumor tissue samples are collected and shipped. Number 4, QC of the submitted tissue and NGS sequencing. And then 5, the manufacturer, in this case Moderna, will select the patient-specific neoantigens and proceed to manufacture. The manufactured INT is then shipped to a distribution center, and from there, once the patient is in the clinic to receive their dose, an individual dose will be shipped to the site. This will happen 9 times every 3 weeks, and is then administered by the healthcare provider to the patient, to the individual patient. So to stress here again, this is an individual therapy, so you cannot store large amounts of this therapy at sites. Every batch has to be manufactured for each patient, and this is a complex process of a chain of manufacture for each patient's batch. Importantly, at least initially, Intismeran will be combined with Keytruda or pembrolizumab. This may improve the anti-tumor activity by combining these 2 therapies with different mechanisms of action. Keytruda is now approved in multiple indications. How does it work? You can think about an anti-PD-1 such as pembrolizumab to release the brake on the immune system. T cells have PD-1, and then this PD-1 can be blocked by tumor cells with PD-L1 or PD-L2, and therefore shielding the tumor cells from T cell killing. By blocking this interaction, the T cells can effectively kill tumor cells. We have a very broad program at Merck using pembrolizumab, approximately 28,000 patients in 25 active phase 3 trials in more than 10 tumor types as shown here. So this gives you an idea of the potential breadth of combining pembrolizumab with Intismeran in the future. Just focusing on melanoma and give you a very quick overview of melanoma skin cancer. As you may know, it is important to go to your dermatologist every couple of years for a skin check. And luckily, most melanomas are diagnosed at a very early stage, stage 1 or stage 2, which will be then excised by a biopsy or surgery. And this will be curative for the vast majority of patients. However, there's a subset of about 20% of melanoma patients where the melanoma is recognized late in stage 2B, 2C, or stage 3, or even stage 4 disease, where surgery and systemic therapy is needed to prevent a recurrence. You can see here the risk groups. Again, the early detection, very, very good outcome, more than 95% 5-year survival. However, in yellow and in red, you see here the high-risk groups and the very high-risk groups, where the melanoma-specific survival probability drops to up to only 24% at 10 years. So this is what we're focusing on. These patients are at high risk of recurrence, and there's still a high unmet need of therapy. We have conducted 2 phase 3 studies in this population with pembrolizumab as a monotherapy compared to placebo. Keynote 716 in stage 2 and Keynote 54 in stage 3. You can see here a significant benefit in recurrence-free survival for pembrolizumab versus placebo for both subgroups, with hazard ratios of about 0.6. What I will show you in the next slides is a comparison of pembrolizumab plus Intismeran versus the green line here. So keep in mind the next Kaplan-Meier curves are compared against this active control. This is Keynote 942, a phase 2 study, updated data, 3 years follow-up presented at ASCO this year. This was in a very high-risk population, stage 3B, 3C, 3D, and 4 resected cutaneous melanoma, disease-free at study entry, and tissue available for NGS, as I explained before. Randomization was 2-to-1, so either Intismeran plus pembrolizumab, about 100 patients. Q3 weeks up to 9 doses IM plus pembrolizumab IV, Q3 weeks up to 18 doses or 1 year, versus pembrolizumab monotherapy, 50 patients. Primary endpoint recurrence-free survival, secondary endpoint DMFS, distant metastasis-free survival, and safety. Overall survival was an exploratory endpoint. What we show here at 3 years, that we see a sustained and clinically significant improvement of RFS recurrence-free survival of the combination over pembrolizumab with a hazard ratio of 0.5. Importantly, for distant metastasis-free survival, so this is the time that it takes for a patient to develop a distant metastasis in either lung, liver, brain, or a distant lymph node. So this is, of course, of much higher impact to a patient than the local recurrence. And here we see an even better hazard ratio of 0.4. You can see in red the combination curve. There seems to be a development of a plateau at 3 years of very few new recurrences for distant metastasis, as well as for pembrolizumab. We also see an encouraging trend in overall survival. However, this is exploratory and the data remains immature. How did this develop over time from 2 years, 3 years, and now 5 years? The hazard ratio remains very consistent. This is important since this INT therapy or therapeutic cancer vaccine was only given for 9 doses over 6 months initially. And it's very encouraging to see in this phase 2 study now long-term follow-up of 5 years, sustained benefit. Safety, very important for an adjuvant therapy. We do see that there is no potentiation of immune-related adverse events, as we see with pembrolizumab, by adding Intismeran as another immunotherapy. All Intismeran and pembrolizumab-related adverse events, or the vast majority, were low grade and transient, and the most frequent adverse events were fatigue, injection site pain, chills, and fever, pyrexia, as well as injection site reactions like redness or swelling. And this can be expected from an mRNA-based therapy such as Intismeran. We have also started looking at clinical parameters of the mechanism of action. And what we can see here on the left is that the combination therapy increased the clonality of T cells upon therapy from the baseline to long-term follow-up for the combination therapy, but not for pembrolizumab alone. And we can also see that the combination therapy increased novel TCR clonotypes, which in this study we did not show that these are specific to the neoantigens due to how this clinical trial collected samples, but we do have from a very small number of patients also indications that we see neoantigen-specific T cell clonotypes coming up. We were also able to connect this unique T cell novel clonotypes to response. On the left, Intismeran plus pembrolizumab patients that did not have a recurrence have an increase in unique novel clonotypes versus in pembrolizumab monotherapy, as expected, we do not see this association with recurrence. Based on these encouraging data from the phase 2 study, we have initiated a phase 3 study, INTerpath-001. This is also an adjuvant melanoma, comparing Intismeran pembrolizumab versus pembrolizumab. This is a larger study, about 1,000 patients, and we have extended the population to stage 2 disease. This is where pembrolizumab as monotherapy is standard of care. So this study enrolled patients with stage 2B to C, 3, and 4 melanoma. Again, tissue had to be submitted for next generation sequencing. Patients were, again, after surgery, randomized 2-to-1 to Intismeran Q3 weeks times 9 doses plus pembrolizumab, this time Q6 weeks to change in the formulation of pembrolizumab times 9 cycles for 1 year versus pembrolizumab plus placebo for 1 year. Again, the endpoints here were RFS, DMFS, OS, safety, quality of life. This trial is now fully enrolled, and we are following up patients for events. The readout of this study is event-driven. We have also set up an extended program based on these encouraging results in melanoma, going into other tumor types, initially focusing on immunosensitive tumors with a high tumor mutational burden, where we can expect to be able to identify neoantigens of high immunogenicity. These are INTerpath-02 and 09 in adjuvant non-small cell lung cancer. One is a post-surgery adjuvant therapy, and the other one is another interesting approach in patients that received neoadjuvant chemo plus pembrolizumab, but did not respond to the neoadjuvant therapy, so non-pathological complete responders. We also have now an ongoing study in stage 1 non-small cell lung cancer. This is even earlier disease where standard of care at the moment is observation. In addition to that, we're looking at renal cell carcinoma, muscle-invasive bladder cancer, non-muscle invasive bladder cancer as other tumor types that have high TMB and are immunosensitive. And we have 2 phase 2 studies in advanced disease, focusing on first-line melanoma and first-line squamous non-small cell lung cancer. This will be really interesting to see if a therapy such as INT, which is essentially a therapeutic cancer vaccine that will take some time to, 1, manufacture, but 2, to generate an immune response is applicable in an advanced disease. So I'll stop here and welcome any questions. And please watch this space. We are really excited about the readout of INTerpath-001, our first phase 3 study in adjuvant melanoma, and hoping that we will be able to bring this therapy, which could be really groundbreaking, to patients, first in melanoma and then in other tumor indications. Thank you.
Thank you very much, Clemens. Really, truly important and groundbreaking medicine here once it comes to the market and comes to patients. I think certainly Merck has led the field of cancer immunotherapy, and I see that there's a lot of really important contributions the company is making. So let me start with the first question here. How do you design neoantigen epitope sequences in the mRNA vaccine? You see differences in the expression efficiency depending on the epitopes or the polypeptides that are being designed in the vaccine itself. If I could add to that, you mentioned that you're including up to 34 neoantigens or neoepitopes in the vaccine. How are those being selected or prioritized, given there may be more than 34 epitope sequences?
Yeah, both are good questions. I cannot go into too much detail. So Moderna is the manufacturer and holder of IP for the manufacturing of the INT. melanoma is a high TMB tumor, so there's usually several hundred potential neoantigens, where the neoantigen selection of those 34 is the critical step. Most of this is still proprietary. We hope to be able to share more details of the selection process and the algorithm in the future. Regarding the difference in expression efficiency also here, so since Moderna is the manufacturer of this therapy, I cannot go into too much detail, but this is part of the algorithm. Is not only the immunogenicity, but also the expression efficiency, and has to be balanced.
There's another interesting question here. It's really more towards the manufacturing. Obviously, it's one batch, right? I mean, you're releasing one batch for one person. Are those personalized vaccines produced under full GMP? And can you speak a bit more about the challenges of really, this is quite groundbreaking that it's a single batch per person.
Mm-hmm. Yes, sure. So Moderna has built a manufacturing facility specific for INT, which is located in Marlborough, which is outside Boston. And this is a dedicated space for this. And it is at the moment, this is not an approved therapy, not FDA approved, but it will be GMP, full GMP, and it will be FDA inspected before this will be used. At the moment, this is clinical GMP. You can imagine that there is a manufacturing train where the NGS sequence comes in, and then one patient, one batch within several hours is manufactured by a team, semi-automated. And at the end, you have this one batch plus additional samples for QC, and then each batch runs through QC analysis before it goes out to a patient. And all of this is done in a sequence that takes these at the moment about 6 weeks to complete.
One last question here, or the one I've seen. Okay, there's a couple more. Could you expand a bit more about the possibility of neoantigen evolution post-sampling of the patient's blood?
Yes, that's an interesting question. So it's not only neoantigen evolution is one that we are not so worried about. The other one is heterogeneity, intra-patient heterogeneity. We only have one biopsy that is from a specific location within the tumor. Evolution, yes, but mostly under therapeutic pressure. That's why the tissue should be ideally collected not more than a few months earlier, and there should be no intervening therapy like chemotherapy or immunotherapy, which would then have evolutionary pressure on the tumor. This is something that we will have to look at in the future. We are trying to collect in clinical trials on treatment biopsies and also post-treatment biopsies to see if any of these neoantigens are edited out and then lose their effectiveness. You can think about we are targeting 34 neoantigens. You only need a few of those for an effective immune response. You don't need all 34. So this is one hedge, and the other thinking is that most of these neoantigens are passenger mutations. There's no evolutionary pressure on the tumor to lose these before the therapy comes in. once the therapy comes in, of course, there is pressure to lose those neoantigens. But before, these are just passenger mutations that should be expressed in most of the tumor cells, wherever they are.
Excellent. Let's move on. Thank you very much, Clemens, for a very, very interesting talk. And we will move
My
on
pleasure.
to the last speaker here.
Thank you very much.
The next speaker is Dr. James Moon. Dr. James Moon is a chair and professor in the Department of Pharmaceutical Sciences at University of Michigan in Ann Arbor. He received his bachelor's degree at the University of California, Berkeley, and a PhD from Rice University, and a postdoctoral at MIT. Now, Dr. James Moon, Dr. Moon will talk about a different way of approaching or using vaccine as a platform, where for the first three speakers, we talked about the ability of vaccines to induce pro-inflammatory, or in this case, strong immune responses against antigens. In this case, it's now the use of vaccines to tone down the immune system in such a way that it would induce autoimmune tolerance. Dr. Moon.
All right, thank you very much for your kind introduction. We'll discuss our platform that we are developing for inducing antigen-specific immune tolerance. As you know, there are now 100 different classified autoimmune diseases affecting all major organs and tissues. And NIH estimates up to 9% of Americans have autoimmune conditions. But current therapies only treat the symptoms, but not underlying causes. And we believe restoring immune tolerance may be the key for potential cure of many of these autoimmune conditions. Based on that, we are developing a platform that can be used for vaccination against autoimmune disease. We have a platform called the Nanodisc that's completely made of synthetic peptides that are delivering autoantigen peptides loaded onto what we call nanodisc. This nanodisc is formed by complexation of phospholipids and ApoA mimetic belt peptide that are derived from high density cholesterol, known as good cholesterol. The product forms these beautiful 10 nanometer size nanodisc that's ideally designed for subcutaneous injection. And due to this small size, they are entering lymphatic vessels, targeting lymph nodes, allowing us to deliver these autoantigen peptides to key immune cells in lymphoid tissues, including dendritic cells, that causes induction of antigen-specific regulatory T cells and TR1 cells. We are quite excited about this because the immune tolerance is mediated by these precisely cells we are trying to induce, Tregs and TR1s. And using this platform, we can attach many different autoantigen peptides or epitopes onto our platform. Once again, our technology targets lymph node and tolerogenic organs. As I'll show in a couple of slides, we have a very strong preclinical data set showing what we call bystander suppression against multiple antigens. And we have a broad IP protection for the technology, allowing us to target these organs using facile subcutaneous injection. And because our platform is based on synthetic peptides and phospholipids, this is a fully synthetic platform that can be readily manufactured with a good control for CMC. So let's go over some of the key data set. This is an in vitro assay showing that nanodisc will induce antigen presentation and PD-L1 upregulation on dendritic cells. This is dendritic cells that are cultured with our nanodisc, delivering CD4 epitope. And we are looking at peptide MHC2 complex presentation on cell membrane over time. We see here that Nanodisc is promoting far better antigen presentation on dendritic cells compared with the equivalent dose of free peptide. And as the previous speaker mentioned, cancer cells upregulate PD-L1 to promote immune suppression. So we intentionally designed our nanodisc to promote PD-L1 upregulation on dendritic cells. We achieved that by screening different phospholipids. We found the proprietary phospholipids that promote PD-L1 upregulation on dendritic cells, and we put that signal into our nanodisc. So as you can see here, our nanodisc is promoting stronger, far better PD-L1 upregulation on dendritic cells compared with the free peptide control. This is showing that our nanodisc can promote signal 1 as well as PD-L1 upregulation, which are believed to be the key signal for inducing Tregs and TR1s. Let's look into the biodistribution of our nanodisc. As I mentioned, we are giving our nanodisc subcutaneously, and this allows us to target multiple lymphoid tissues and tolerogenic organs all together in a very simple, facile approach. In mouse models, after subcutaneous injection, we see multiple lymph nodes that are lighting up with our nanodisc, including axillary lymph nodes, inguinal lymph nodes, and after hitting multiple lymphoid tissues, they are entering blood circulation to target liver and spleen, which are known as tolerogenic organs. So we have a unique way to hit multiple coverage of lymph nodes and spleen and liver, known as tolerogenic organs for immune tolerance. And let's go into some of the preclinical data set we have. We tested our nanodisc using widely used mouse model of multiple sclerosis, known as EAE. Here, in particular, we use MOG CD4 epitope to induce the disease. And at the peak of the disease, with EAE score of 4, both hind limbs in these mice are completely paralyzed. At the peak of the disease, we gave 3 simple weekly sub-Q injection of our nanodisc, delivering a CD4 epitope that is used to induce the disease. And what you can see here is that nanodisc is reversing the disease even with the first injection. And by the third injection, we see alleviation of EA score down to 1 or below. And if you inject free peptide, you don't see any movement in EA score. We even compared our nanodisc to some of the MS drug that patients are taking, Gilenya. This fingolimod sequesters T cells in lymphoid tissues, therefore limiting their infiltration into brain. If you give oral Gilenya in these mice over 30 days, you can see it's controlling disease from EA score 4 down to 2. But as soon as you stop the treatments, the T cells are liberated and they go to CNS, causing fatality within 1 or 2 weeks of stopping the treatments. In contrast, our nanodisc, with just 3 sub-Q injections, was able to control disease up to 85 days in this study, showing the potential of inducing immune tolerance with our nanodisc platform. To push the envelope, we used even more aggressive EAE model where we used the whole MOG recombinant extracellular domain at MOG 1 to 125 to induce the disease. Because it has multiple T cell and B cell epitopes, it kills mice even faster within 2 weeks. And even in that harsh condition, our nanodisc, given at the peak of the disease, was able to reverse EA score down to 1 or below and maintain the low EA score over 100 days. That's quite exciting data showing efficacy of our nanodisc in very hard to treat EAE models. And now we'll show you some data showing that nanodisc induces and mediates this efficacy through induction of antigen-specific Tregs. So in the same EAE condition study, we basically try to deplete Tregs to see if Tregs are key mediators of immune tolerance. In the same condition, the MOG nanodisc is reversing the disease. And after nanodisc treatments, if you give anti-CD25 to deplete Tregs, you can see abrogation of the efficacy, showing that CD25 regulatory T cells are likely the key players that are crucial for maintaining this long-term tolerance with our nanodisc treatment. The holy grail in vaccination against autoimmune disease is to induce what we call intermolecular bystander suppression. As you know, autoimmune disease is caused by many different autoimmune antigens, and it's hard to select which antigens to target as a major candidate for product. So it'll be really nice to pick a couple of antigens and induce bystander suppression so that you can go after multiple pathogenic antigens found in autoimmune conditions. So to mimic that condition, we used this hybrid EAE model. We crossed Black 6 with the SJL mice and then induced EAE using MS relapse remitting condition, EAE induced by PLP antigen. When we use the same antigens to load onto the nanodisc and treat these mice, we can see very nice efficacy showing complete inhibition of EA induction. What's even more interesting is that even when we use related autoantigen, MOG epitope, attached onto the nanodisc, this MOG nanodisc is also able to inhibit induction of the EAE. And because we are using different antigens on nanodisc from what was used to induce the disease, this is showing what we call intermolecular bystander suppression. We believe our nanodisc is inducing regulatory T cells that are mediating these bystander suppression. And this is the data showing that in the same condition, when we use our nanodisc to deliver epitopes, we can take out the CD4 T cells and analyze by flow cytometry to look for their T cell specificity. When we use our nanodisc delivering PLP antigen, you can see that we do induce PLP-specific regulatory T cells as expected. But we also see PLP nanodisc is inducing MOG-specific Tregs. This is once again showing the idea of intermolecular bystander suppression. Of course, if you put multiple antigens onto the nanodisc, we see induction of epitope-specific Tregs, both against the PLP and MOG. This is showing the nanodisc is inducing bystander Tregs to multiple epitopes. To study their functions even more closely, we designed this study. We used F1 mice with a C57 crossed with SJL mice and give the nanodisc treatments using either PLP nanodisc or MOG nanodisc. And then we adaptively transfer polyclonal Tregs from these mice into naive recipients and then induce the PLP in this condition. The idea is that PLP nanodisc will induce PLP-specific Tregs that are controlling the disease against the exact epitope PLP. But also, the MOG nanodisc will induce polyclonal Tregs that will control the disease against the PLP epitope. And precisely, that's what we saw, as you can see here. The polyclonal Tregs obtained from both PLP-induced mice as well as MOG nanodisc-treated mice were able to control the disease in this study. So this is just showing that nanodisc carrying one type of antigen, exerting intermolecular bystander suppression by promoting polyclonal Tregs with the bystander functions. Based on this, Evoke Therapeutics is now pursuing multiple indications in autoimmune disease. The top internal indication we are going for is a celiac disease because there's well-defined gluten-specific epitopes found in human patients. So we are putting those epitopes onto our nanodisc and hopefully will induce regulatory T cells as well as TR1 cells in human patients. And we are aiming to launch the first phase 1 study within a year. And we also have indications targeting autoimmune conditions, PBC, vitiligo, IBD, as well as multiple sclerosis. And we have ongoing partnership with major pharmaceutical companies, including Gilead and Sanofi on multiple other indications. To summarize my presentation, we have developed what we believe is a platform for delivering autoantigen peptides in an immune-tolerizing manner. We designed PD-L1 inducing phospholipids onto our nanodisc platform. So when dendritic cells see our nanodisc together with autoantigen, it induces antigen-specific Tregs and TR1s. And the major benefit of our nanodisc system is that we can do this using a subcutaneous injection targeting multiple lymphoid tissues, including liver and spleen. And we also have ability to attach multiple autoantigen peptides to go after complex autoimmune conditions. So with that, I'd like to take any questions you may have, and thank you for your attention. Thank you.
Thank you, Professor Moon. We have one question here. I guess you spoke a little bit about that one in terms of just expanding a bit more on what makes your nanodisc really induce immune tolerance. And if I could add to that, mine is from your description is the lipids, which really induce PD-L1 expression. So are you also, that's one mechanism, but obviously going from the mouse to the humans are far more complex systems. Are you also considering other adjuvant in the nanodisc, like people have used IDOs, vitamin D3, DC targeted immune modulators?
Yes, we can definitely put small molecule modulators onto nanodisc. So we have ongoing aims to internalize and encapsulate those small molecules onto our nanodisc. And we have a strong data set showing induction of immune tolerance using our nanodisc with immune modulators. But even without immune modulators, we are seeing this PD-L1 upregulation on dendritic cells. And we have shown this using preclinical models as well as human samples using dendritic cells. And we believe our nanodisc with unique phospholipids are programming dendritic cells into tolerogenic phenotype. And in that condition, when we deliver signal 1, the epitope, the antigen-specific Tregs are induced. And we believe our ability to target multiple lymph nodes with a simple sub-Q injection will offer a convenient method for potentially home treatments in the future for patients.
Uh, there's one question here from Sita. In the introduction, you talked about cure instead of treatment, which is the common paradigm right now. Do you think this approach will be curative?
That's to be tested in, of course, patients, but at least in animal models, as I showed in the EAE model, just the 3 sub-Q injection was sufficient to control disease up to 100 days at the end of the study. Hopefully, we'll see something similar in celiac disease patients in upcoming human studies.
Um, How do you mechanistically explain PD-L1 on DC could induce, I guess, Tregs in this case? That's a question from June.
Yes, if you look at cancer immunology literature, there are studies showing that metabolites, small molecules, as well as phospholipids from cancer cells turn intratumoral dendritic cells into tolerogenic immunosuppressive phenotype, leading to tumor growth. So we are turning this idea around for potential use in autoimmune conditions. And we believe we found a key signal, including phospholipids, that turn dendritic cells for tolerogenic phenotype for immune tolerance. But as I mentioned, we have ability to deliver other small molecules and immune modulators to further turn DCs into tolerogenic phenotype.
Perhaps if I could, there's one more question that would be for me, in that could you at least describe the competitive landscape here? Because there are other companies
Right.
which are in celiac disease, which I understand celiac disease is really an excellent target, but an unmet medical need, but also a strong place to establish proof of concept, right, for inducing antigen-specific Tregs and looking at the biological effect. Could you speak to where the field is right now?
Right. So there are several other biotech companies that are using nanoparticles to deliver autoantigens as we are doing now. But those companies are mainly focusing on intravenous injection, targeting liver or spleen. But we believe our unique ability to deliver our autoantigens after subcutaneous injection will be a major benefit for many different autoimmune patients. Rather than going to clinic for IV dosing every 3 months or so, potentially our nanodisc could be dosed sub-Q at home. So this will be a very convenient as well as effective way to target multiple lymph nodes, liver, and spleen. So I think that's the key differentiating factor for us. And we chose celiac disease as our first indication because there have been extensive studies showing that you can give gluten challenge after initial treatments to see if upon gluten challenge, whether Tregs are able to control the disease and symptoms. And you can also collect their blood and look at Treg induction for a potential biomarker and PD readout. So the upcoming phase 1 study hopefully will show us not only long-lasting pharmacodynamic effect of our nanodisc in inducing Tregs, but also controlling against the challenge, the gluten challenge.
One last question here from the panelists. Can you expand on the methods for production of the nanodiscs? How well do they spontaneously form the unique structures that you're showing?
Yes, this is a great question. Our nanodisc makes a 10 nanometer sized nanodisc with a simple self-assembly process. So by simply mixing our phospholipids and the ApoA mimetic peptides, they self-assemble into homogeneous 10 nanometer sized particles. So it's a very simple, and we attach autoantigen peptides using this self-assembly process. And we believe this 10 nanometer size is the key for lymphatic delivery. If you look at size of albumin or antibody, which are known to drain to lymphoid tissues after subcu injection, they roughly fall between 8 to 12 nanometers. So we think we are mimicking that process using our 10 nanometer size nanodisc.
Excellent. Well, thank you very much, Professor Moon, for a very interesting and stimulating talk about tolerizing vaccines or vaccines able to induce immune tolerance. Definitely a very innovative and cutting edge field that many pharma companies are really paying attention to. And congratulations on advancing your program at EVOC. I'd like to thank all the speakers here because we were able to give you, the community, the vaccine community, really a very diverse set of talks and topics, ranging from long COVID therapeutic vaccine to acne to cancer immunotherapy, and now using vaccines to reverse immune responses the way we know it in the case of inducing immune tolerance. With this one, I'd like to give the floor, I believe, Ed, when it comes to the last few announcements.
Yep, I think Jeff's going to speak to those. I'll be sharing the slides.
Sounds good.
Yeah, I'd like to echo Danny's comments and thank you all for participating. We have these webinars pretty frequently, and we hope you'll continue to join us. But we'd also like to encourage you very much to join us at our annual Congress, which is taking place this year in October, the 12th to the 14th of October in Antwerp, Belgium. Be a great opportunity to catch up with old friends, meet new ones, and hear about the latest developments in vaccines and immunotherapy. And it's certainly not too late to register. Registration will be open up to and through the Congress, but there is an early bird deadline at the end of this month. And if you're interested in actively participating, there's a late breaker abstract deadline, the 1st of September. We also have some upcoming webinars. Our next generation vaccinology series will have 2 presentations, one on Zika vaccine and one on the Middle East respiratory syndrome, and that will be on August the 6th. And then we have another one shortly after that on August the 12th with a very timely topic, given the current environment, on vaccine confidence, and that will be given by Roxandra Dragia-Ockley, so please join us for that as well. ISV is not-for-profit that relies heavily on generous support from our sponsors, and we would like to thank them. Here are some of the sponsors that are helping us for this year. And if you or your organization is interested in providing support, please reach out to Ted Gibson at the email address down there. We would certainly welcome your support. We are active on social media, including the presentations you've seen here today. They will be posted on YouTube as videos, but we also are active on these other social media platforms, so please feel free to follow us. The QR codes are there if you want to connect. And then finally, if you're not already a member of ISV, please consider joining. There are a number of benefits. You can save money on your Congress registrations. You'll have access to travel awards and mentoring and professional development. You could actively participate in the society with the committees that we have. We put out an exclusive newsletter that you'd be up on the mailing list. And the membership rates, as you can see there on the right, are quite modest. And we would very much enjoy having you part of the society, so please consider joining. And with that, we'll close the webinar and look forward to having you on a future one and seeing you in Antwerp.